Good morning, everybody. Welcome to Toulouse. Thanks for coming to this third Health Economics Conference. So we'll start first with keynote speaker. So Liran Einav is a Charles Schwab Professor of Economics of the Department of Economics of Stanford University. And I'm not going to do all this CV because it will be too long. He's also the director of the IO program of the NVR. He has been editor of the American Economic Review, of Econometrica. He's a fellow of the Econometric Society of the American Academy of Arts and Sciences. And of course, a very good specialist of healthcare system. So Liran, you have 1 hour, including questions for your keynote.
All right. So when they call your talk keynote, it makes you start thinking if you're supposed to now do some fluff in the beginning to not make it like a regular talk. And I decided like, I'm too excited about this paper and I don't have too much fluff about it because kind of it's not directly connected to earlier stuff that we did. So I'll just give a straight paper. This is joint work with Amy Finkelstein from MIT. And I have an hour. I want to run it as a regular. It's a pretty in progress work. So I want to run it as a regular kind of talk. So feel free to ask questions. I mean, if I listen to myself 15 minutes straight without questions, I get nervous. So let me, and the other thing, I want to thank the organizer for one, having me, and two, for kind of, I don't know if it was intentional to have me in the morning before the jet lag kicks in. So that's useful. So let me start with some motivation for this paper. Yeah. So I don't think, I think it's not new. I mean, it's a very US, I mean, France is a US-centric paper. My guess is a lot of the qualitative kind of points are going to be very similar in most kind of other developed countries. It's not a new fact. Everybody knows this. Kind of the share of the elderly is growing kind of in the US and elsewhere. This is going back to, this picture is going back to the 90s. You know, it was about, 12, 13% of the overall population. If you go back to today, we are talking about like 18% of the US population is like 65 plus. And if people, again, so much you want to believe the projections, but people say it's going to be up to 22% by 2050. What it means is that sort of there's a lot of kind of fiscal pressure on sort of on the different kind of government programs that are kind of out there to kind of try to support the elderly. These are two pictures which are like our best attempt to come up with like the right numbers. So what you see on the left, in the US, the two, again, most other countries have something similar, but the two biggest kind of, fiscal kind of programs that support the elderly, one in the US is Medicare. Medicare is the program that is kind of providing something close to kind of full or close to full health insurance for 65 plus. It does have some other components that are not for the elderly. So this is an attempt to kind of get the right number that is only for the 65 plus kind of people in the US. And what you see here is this is basically per year, this is like adjusted to 2024 dollars per capita, not per capita of 65 plus, but per kind of basically, so we are adjusting partly for the fact that like the share of the 65 plus in the population is growing. And you see that sort of in 1990, we were talking about the Medicare was spending about $1,000 a year per US kind of, citizen. And basically today we are talking about almost like two and a half times kind of more. So we're talking about $2,500. And then the other program that is supporting the elderly is the Social Security kind of administration, which is basically like a public annuity. And here again, because of the growth in the population, we are talking about from like about $2,000 per kind of US citizen, we are going up to kind of $3,500. So between the two of them, it's almost like double. We are over the last 30 years, we have more or less doubled kind of the amount of money per person. So if you think that kind of, per citizen, we are making the same amount of money. Now we are kind of doubling how much we are supporting kind of the elderly. And the question, like, what do we do about it? The one obvious solution, and I think after you see this paper, this solution is even more obvious, at least to most economists, is to just kind of raise the retirement age. Last time I was in France, 2 years ago, I was actually here. I think that was like in France, they had like the demonstration in the everywhere, and I couldn't get a flight out of Charles de Gaulle because sort of the taxis were like not working because I think the Macron was trying to kind of, raise the retirement age. So that's the obvious solution. It's probably not happening anytime soon in France or in the US. So we are not going to talk about that. So what this paper is going to be about is like, well, let's if we keep retirement age more or less the same, and we have the public programs more or less the way they are, the fact that sort of the population is getting older and healthier, what does it mean kind of, for public policy, and how should we kind of think about it kind of going forward? And let me just say again that we're kind of almost done with the basic part of the paper. Like some of the stuff in the end are still in progress. So actually feedback would be useful either kind of during the talk or after. So what's the plan for the paper? The call for the paper is 30 years almost of data on healthcare spending and mortality for Medicare beneficiaries in the US. The key fact that I'll try to show you is that basically, if you compare people in the early 90s in the US to people in 2019, 2018, basically on average, starting, talking about 65-year-old going forward, they gain almost 3 years extra in terms of life expectancy. Interestingly, these 3 years are basically healthy years. So it's not that they're getting sicker, but somehow it takes longer to die. Almost everything is just they're getting sicker kind of later. And that translates to about, $56,000 per person, kind of lifetime Social Security payments. The second part of the paper will basically try to say, okay, this is demographics, it's interesting, but why is it economics? So the second part of the paper is trying to translate this to kind of dollars by basically mapping very granular data on health to what it means for projected healthcare spending. And that kind of comes down, I'll show you more, to about $24,000 per lifetime per elderly, kind of in terms of extra spending. So overall, basically, we projected over the 30 years, we are talking about $80,000 per person that we are committing to kind of to the elderly more just because over these 30 years of kind of health improvement. Sounds like some interesting stuff that I'll go in between. And then the last part of the paper, which I hope to have like 15, 20 minutes in the end to talk about. It might be kind of the most thing that the thing is not just throwing facts at you, but actually make you think a little bit, is we are going to kind of basically take all these facts, use them to calibrate some sort of a macro-style life cycle consumption model with stochastic health and mortality, and kind of use this model to start thinking about, what is, what does it mean for kind of Medicare and Social Security policy, and to what extent. One way to think about it is like we have some Social Security and Medicare policies in place with the parameters in place, and suddenly the entire population is becoming healthier. We're not adjusting the system. We are just kind of, it's an entitlement program, so we are just kind of automatically kind of making us committed to more just because people are getting healthy. And there is a question of over 30 years, like big changes in demographics and health, to what extent we want to keep the system fixed or adjust the system given the demographic changes. So this, we are not going to have a clear answer. It's going to be obviously depends on some of a bunch of modeling assumptions, but at least hopefully I'll help you kind of think about this a little bit. So that's the plan. So let me start with the first part, which is basically just kind of telling you about the data and sort of how kind of it affects kind of demographics and health. So what's the core for the paper? It's basically the underlying data is pretty familiar data set in the Medicare kind of current beneficiary survey. Other people can have access to most of it. This is the rotating panel of Medicare beneficiaries. It covers about 10,000 people a year, kind of typically you're there for 3-4 years in the panel. And for everything I'll do in the paper, it's only the 66-year-old and above that we're going to look at. The unique aspect about this panel that you don't get from regular claims data that many people have is that they ask kind of the survey kind of a lot of questions about their health. And that's kind of going to be important for everything I'll do. So let me just go through it kind of carefully. There are basically 30, 31 variables, all of them binary variables that we are going to kind of use in the analysis. So the 6 of them are activities of daily living, ADLs. These are basically questions like, can you bath by yourself? Can you dress by yourself? Can you eat by yourself? And stuff like that. The next 6 are what they call instrumental ADLs, which is like slightly more complicated sort of binary question. Can you shop by yourself? Can you kind of manage your money by yourself? And this type of thing that are not like, not less what you do at home, but more you do outside of the home. Then the next 5 are what they call functional limitations. These are stuff that you don't have to do, but maybe it would be good if you could do. So it's a question like, can you walk like a quarter of a mile by yourself? Can you raise your kind of hands above your shoulders and hold it kind of for 30 seconds and questions like that? And then the last 14 are basically different sort of questions about chronic condition. Were you ever diagnosed with cancer? Were you ever diagnosed with other diseases? And then basically they get to sum up all these kind of 14 things. So we are going to use these 31 binary variables throughout, and we see them for every person. Typically for a person, we see them kind of over multiple cycles of the survey. The other thing they ask them about their medical spending, and they kind of cross-validate it with kind of medical claims. So there is some good match between their particular health to total healthcare spending and to some subcategories like, inpatient, outpatient, the pharmaceutical drugs and stuff like that. And the one thing that is critical for this paper, and this is not available for regular kind of data access for this kind of data, is that they linked it for us, and we have to thank David Cutler for helping us get these particular linkages. And that's what drove us kind of to write this paper. They linked for us basically this medical survey data with subsequent mortality. So for everybody who were in the survey, we know if they died by 2019, we know when they died, which year they died. So that allows us to kind of run this stuff, because otherwise, if you just regular kind of access to this MCVS data, you just see the people who are alive, you have no idea what happened to them subsequently. Okay? Yeah.
Okay. How do you think about how Medicare spending changes mortality, or is that the evidence of like how the evidence says this?
So well, we can talk. So right now, I'm just holding it as fixed in the sense that sort of your health is your health, and we are going to create some mapping. You'll see it in a second. We're going to create like a fixed mapping from health to death. And later, when we are going to start playing with some modeling assumption about, we are going to basically assume that health maps to spending, and spending is not affecting your health beyond kind of what you're doing. So you'll see it in a second. But partly because who knows and then partly we think, well, kind of on the margin, we probably kind of the thing that really affect our health a lot, we're probably going to do anyway. So the thing that is kind of more responsive is probably the stuff that is probably not as central, but that's kind of an assumption. So. And then kind of the last part on the data stuff, and I want to just go slower because it's going to be kind of an ingredient that is going to feed into a lot of the analysis later. We particularly, again, after playing enough with the data, we take the ADLs and IADLs. This is the first 12, the first 6, and the second 6 kind of in the list above. And we classify it into, just to make it more manageable, we classify it into 5 mobility levels. So we have like basically people with none of them. So think of this kind of as turned on or turned off. So if none of this 12 is turned on, that's kind of your 0. You're the healthiest kind of in the healthiest group. That's about half of the person-year observation in the data. And then we kind of bucketed sort of the other kind of cases to basically 4 more or less equal sized groups. So basically we are going to classify people into kind of 5 different kind of morbidity groups based on how many of this, just simple count of how many ADLs and IADLs are turned on. And then and because it's kind of sufficiently kind of, not as granular, that allows us to estimate directly off the data, nothing sophisticated, what you want to think about a 5x6 matrix of transition matrix by age, by year. So basically for say like a 70-year-old in 1995, I can basically get you sort of, if you were in morbidity group 1 to 5, what's the probability that you ended up in some other morbidity group next year or that you died? Okay, so this 5x6 matrix by age by year, that's going to be a fixed component that we get off the data, and we're going to feed into kind of a lot of what we're going to do next. There was a question. Yeah. Totally. So in some sense, yeah. So I'll say you later when we are going to convert stuff to spending. One of my arguments would be exactly this: that like you have different sort of binary variables, and they cost different. Certain things are going to be very cheap, and certain things are going to be very expensive. So we want to think about them differently. Here, partly we are kind of for the purpose of if we want to do kind of everything by age and year, you need to kind of aggregate it more, so you don't have to sparse of the data. So this one we are just counting the ADLs and IADLs. But for that reason, we are maybe not counting also the functional limitation, which we think is not as kind of central. So it's a judgment call, but yeah. So we are just counting for this purpose. So let me first show you a bunch of stuff of the data. The first one. It's going to build to the main kind of result. So this is just directly of the data. On the x-axis, this is the age of the people. The bars are just kind of the proportion of people in the data. But then the key thing to note is the different lines. On the y-axis here, this is just for each age, the mean number of ADLs and IADLs that are kind of turned on for these people. The red one is for like the last 3 years of the data. The blue one is for the first 3 years of the data, and the green one is for the middle kind of the data. And kind of what you see is that sort of conditional on age, people are getting healthy. Sort of the number of ADLs and IADLs is going down by about 2 on average, like over here. And maybe the more kind of useful way to think about this graph is think about it horizontally. If you think that sort of age is just a number, and it's really age is what, how sick you are, or how unhealthy you are, or how frail you are, then you can think about, well, if you were, like an 85-year-old here in the early 90s, the equivalent in terms of overall health coverage measured by the ADLs and IADLs is something like about 90-year-old kind of, in the late 2010s. Okay, so in general, people are getting kind of healthier. The other fact, which again, directly of the data without doing much, is to say, well, the process of death didn't change much. So if you ask, are people living longer because, they're getting sicker later, or is it because they get sick at the same rate, but then now we have a better technology to kind of keep them alive longer, and like all this literature about sort of extending life and stuff like that, it's kind of almost all of it is the former. So this is basically, we can do it for the last years because then we don't have enough stuff. But what we do here is basically the same graph, except that we count age, not kind of in terms of your biological age, but kind of age backwards from, going back until you died. And what you see here is that sort of, if you look at kind of the blue line, which is like the early 90s, and the green line, which is sort of the early 2010s, it's kind of, it got a little bit better. People live a bit longer with diseases, but not that much. It's kind of fairly small. So basically the process of death is staying more or less stable, and it's kind of, when you get sick is kind of really when things kind of are changing. And then you put this stuff together into slightly more of a machinery, and you get kind of overall kind of life expectancy. So let me just tell you in words what we are doing here. I already told you we estimate this 5x6 kind of transition matrices by age by year. So if you take all the 66-year-old in 1992 and you run them through the system, what does it mean? So I run them through the transition matrices. It's like the way they do kind of mortality tables. So I'm not running them in time. So I'm basically running the 66-year-old in 1992. You start them with like some sort of the distribution of morbidity in 1992 for them. And then you run them through the transition matrix estimated in 1992, and you get what their health would be and whether they die by 67. Then you go back to the 67-year-old kind of in 1992 and run it through 68 and so forth until everybody dead. Okay, and then you ask, okay, how many years are people kind of living on average? And you get that sort of in the early 90s, people, again, starting at 66, the life expectancy is 17.4. in the late 2017 or the late 2010s, they are kind of 20.1. Okay, so that's kind of the 2.7 extra years that people are alive. And what you see here is that basically, so what I'm showing in the other graphs here, this is basically, so think about it sort of, I kind of run this kind of transition matrices throughout, so I can actually count not only sort of how many extra years you got or how many total years you're getting, but also kind of where do you spend these extra years? Like what fraction of the time you're spending in kind of morbidity 1 kind of years, morbidity 2 years and stuff like that. So the blue line, the blue bars here is basically kind of just decomposing the extra 17 years that you're alive kind of to how many years you spend in each morbidity group, and similarly for the red. So if you look at sort of on the right-hand side, this is the differences, and you see that the 2.7 extra years that you get overall, basically all of them are coming from 2.7 years that you're spending in kind of the healthy state. And then kind of for the other states, nothing dramatically changing. Okay, so again, just consistent with what I showed you before, that mostly it's like you're just getting kind of sicker 3 years later, everything else is staying more or less stable. Yeah, Ben.
Any year, you would benefit an indicator of healthy data.
So again, remember, all this is life expectancy in the sense that it's all within the year. So I don't use the future. I basically just look at the 92-year-old and keep running within 92, kind of iterating this, but adjusting for the ages. Okay, so everything is, that's what they do when you know, actuaries are doing mortality tables, they do the same thing. Yeah.
Perfect sense, but it's more of like a continuous variable. Typically, you have a confirmation.
Well, we are not. It's not binary. The underlying variables are binary. For this exercise, the variable is like integer 0 to 12, so or 0 to 5. So it's somewhere in between. But that's why But that's exactly what I'm showing with the. So at least for these 5 kind of health categories, discrete but not binary. Kind of all the action is basically coming from people living in the healthy state. Which is, I don't know, is it healthy? But it's the healthy state is people is basically people who are basically did not check in any of the 12 ADLs and IADLs categories. So everything that they can do. You know, I guess we can argue how healthy they are, but that's kind of what we define as healthy. Yeah.
Life expectancy. So at the end is.
Yeah, so this is 66-year-olds. So if they live 17. So this is our life expectancy as of age 66. So if you have 17.4 in the early 90s, that means that your life expectancy is 83.5 or 10.4. And if you are like in the late 2010s, that's basically like 86. I should mention, I guess, as I think everybody knows, I mean, this is like not gender specific. So we can cut it by, we can do it. We did everything. I'm not showing you anything, but all the patterns I'll show you are going to be very similar for men and women, except that women are kind of 3 years kind of living longer. So everything, this is averaging the two basically. Yeah. Yeah, we can. We did it. Nothing was. Yeah, I mean, if you start sicker, you're going to live less, and we can show you all of this stuff. We are not. I'm not going to show you today. Yeah. No. So well, this one I'm not interpreting. This I'm just presenting a fact. I'm not claiming anything of where it came from. For most of the rest of today, I won't making too much causal kind of analysis, but yeah. So that's basically the main fact, just on health. And then the next question or the next part is like to say, okay, we are all economists here, like sort of what does it mean for spending, for commitments, and then for dollars. So that's where we're going kind of next. So what do we do for this second part of the paper? We we basically take the 31. So I'm moving back to the underlying 31 binary variables that I kind of mentioned in the data slide. And we are running like a pretty standard random forest algorithm to try to use the 31 binary variable to predict total spending. We do it the same. Well, we predict total spending, but then we also remember like the health spending that we have from the survey is not only the total spending, but also some subcategories of spending like inpatient, outpatient, nursing homes, and so forth. So we do the same exercise to predict each one of these components. Okay. The two points to mention on this. The first point, which is related a little bit to your question, it's kind of important to, okay, are we predicting it, to the extent that things are changing? And a lot of things, these are 30 years. So at some level, every time I think that's probably true for many other papers, like every time you show like kind of a time series over kind of enough years, you need to hold something fixed. Otherwise, kind of everything is changing and it's hard to pin it down to anything. So what we do here, which is a judgment call, I'm not sure I'm going to, you could do it other ways, and I don't know that sort of I'm overly kind of wedded to this particular way. But we are basically holding this mapping fixed in the most recent years of the data, which is basically means like, policy in general, Medicare policy, like what we cover, what we don't cover, technology, prices, to the extent that prices are changing. All of these things are kind of in this mapping are held fixed to the end, in the end of the data. It's totally reasonable to ask, well, maybe some of them probably they did, like, Medicare Part D, that's kind of the pharmaceutical drug kind of, stuff in the US, that got coverage kind of in 2006 in the middle of our data. So at some level, part of the reason that we see more spending on kind of pharmaceutical drugs in the US is because now they cover them much more for the elderly. So this is not going to be part of the story here because we are going to kind of create all this mapping based on the most recent kind of years of the data. Again, whether we like it or not, that's kind of what we're doing. So hold this kind of in your head. This is like, these are held fixed kind of based on kind of the most recent years on the data. So if we think about projecting forward at some level, the conceptual exercise is that we are holding technology, policy, prices fixed in the most recent kind of years that we are seeing them. But if we expect them to change in the future, you somehow need to adjust for this kind of in any exercise. The other thing that is kind of important here is like we are predicting kind of health based on kind of this health, these 31 variables. We're not using age for the prediction because part of the exercise is to ask, how things are changing with age. So we don't want to age kind of to be the predictor. What we do instead, we are kind of, that's kind of non-standard stuff. We are predicting spending using the 31 sort of health categories. And then kind of after we create a prediction, we are kind of introducing some sort of, think of this as like sort of proportional age fixed effects. So we are taking all again, I'm not going to go into the details, but we're taking all the people and then basically ask to what extent like an 85-year-old versus like say a 70-year-old are having different spending, and the ratio between them in terms of the prediction is going to become sort of the relative age fixed effect. It turns out that these age fixed effects are really small. And one way to see this, this picture, what I'm showing you here, so the age is on the x-axis, mean predicted spending is on the y-axis. Every color except the dashed black line, every color is basically a different health category, going back to the same kind of 5 health categories that I talked about in the beginning. What you see here is that sort of, again, roughly sort of all these kind of colored lines, except the dashed black line, are kind of stable with age. Which is basically what it means is that sort of the reason that the 90-year-old is kind of much more expensive than the 70-year-old is not because kind of, aging makes you kind of more expensive. It's just because as you age, you're more likely to move from kind of health category 1 to health category 3 or 4 or 5. So that gets you, so the weights between the lines is changing with age, but not kind of how much you spend condition on your health. Which is one way to say, well, if your health data is really good, then age should not have like too much residual effect because basically kind of the health variables are capturing kind of everything that makes you sick, basically. So that's kind of what's happening. And so to the extent that the elderly are spending much more than the younger guys, the elderly younger, it's all coming from kind of people switching within kind of different health categories. Okay? So now we have this exercise, and we create this mapping between the 31 binary variables to spending. And this goes back to the question from the beginning. If you look at some of the literature on aging, they tend to look at they call it different way, right? Like frailty index and aging index, which is basically some version of pure count. So that was the question from before, like sort of this literature tend to kind of look at like a bunch of kind of numbers and just ask, what fraction of them are turned on, and that would be like an index. And that's where we say, well, if you think about spending, some conditions are much more expensive than others. So it's like we don't want to purely count them, so we want to kind of actually think about them through this random forest. And this kind of tells you kind of how much of a bite it gives us. So on the x-axis, this is on the x-axis, this is the number of conditions. If you were just counting the 31 kind of variables, and then on the y-axis, this is log scale. This is like your predicted spending. And each one of them, this box plot, is basically telling you that, well, sort of, with even condition, the number of conditions, they're like big variation, sometimes kind of 3x or 4x variation in terms of how much spending you have, depending on which one are, let's say, the 10 conditions that are turned on. So it's kind of important to go granularly, not just count, which is most of what the literature is doing. Okay, so that's, and obviously, kind of things are kind of moving up with the more condition you have, you're more expensive. But again, there's a big variation. You can be like, this is like, you can be $100,000 a year kind of expensive, or $20,000 a year expensive, depending on kind of what type of conditions are being turned on. So that's kind of the underlying random forest kind of machinery. Now, we take these predictions and then we feed them back into the same kind of exercise that I showed you before. So think of like the same exercise I talked about before when we did the life expectancy. So now when I kind of run you through the life expectancy stuff, on top of what I did before of just asking, what your morbidity group is and how much, and are you dead or not, now I can also attach to it kind of expected spending for each person. And using that, it's the same simulation. We're just simulating forward kind of, again, within the year, the same way we did before, but now we are kind of adding to this kind of spending, either spending overall and spending for each category. So then that comes down to the people are basically, and all the numbers, I should say, in the next few graphs, all the numbers are measured in terms of, per capita lifetime. So take a 66-year-old, run them through the machinery, kind of forward until they die. Every year they're alive, we attach them sort of expected spending for them. Discounting is not changing much this exercise, but just take all this on expectation about 20 years of life and just kind of, add up all the spending that they're going to kind of incur kind of over these 20 years and then add them all up. And you get that sort of, going back to the beginning of the data in the early 90s, the average 66-year-old is going to kind of cost the system. Again, I didn't say yes, what's covered or not. This one is like total in terms of both kind of medical covered and out-of-pocket spending. They're going to cost the system $392,000 kind of on average 20 years. If you go kind of to kind of the late 2010s, they're going to cost the system $426,000. Okay, so basically the difference is going to be $34,000 in terms of overall, call it kind of commitment to kind of to spending, just because they're going to live longer. Now, if you kind of take the right, again, if you % of total dollars, so that comes down to, so out of this, what is it, like out of the $34,000 difference over the 30 years, that means that Medicare is basically on the hook for $24,000 per person, kind of in terms of commitment, okay? Then you can ask, that's kind of less interesting. It's more mechanical given what we saw before, like, where is this spending this extra spending is coming from? So a lot of it is coming from the healthy guys, just because there are many more of them kind of now, many more healthy years that are in the healthy state. So that's what generates much of the extra spending. And maybe more interesting, now we can kind of use the fact, remember I told you when we do the spending mapping, we do it not only for total, but also for the different components. So now I can run the same exercise for different categories. So again, the font is a bit small. So inpatient, nursing home, home health, drugs and outpatient and physicians. And what you see here, that actually it's kind of interesting and somewhat surprising. When people talk about the elderly and the growth in the elderly, I think the general view is that sort of we need to really worry about kind of nursing homes, because now we'll have all these 90-year-olds kind of floating around and they cannot take care of themselves. We need to put them in nursing home and stuff like that. It turns out that actually the inpatient, the nursing home, and home health is like, you know, services they provide you in your home, kind of if you are not mobile enough to go to the doctor. All of them are kind of not changing that much. And almost all of the extra spending is coming from drugs and outpatient and physicians. And partly it's consistent with the fact that people are they're kind of living their lives kind of healthy for 3 more years. So most of the delta is actually coming not from the fact that people are older, just because kind of people are kind of taking 3 extra years before they start getting sick on average. So it's kind of consistent with like drugs and outpatient is actually driving most of the spending. Go ahead.
The knee replacement that are now to be the full OBL. And I'm surprised that there's an increase in spend, including the statins. So, which expensive drugs?
I wish so I don't know. The short answer, I don't know. The survey doesn't tell us. So the survey, it just gets us number for each category. It doesn't give us the claims. We can link it to claims for some of these cases, but not perfectly. But yeah, I think it's super interesting. It's very interesting question to ask these questions, and you need somewhat of a better data to kind of get a good handle on it. Yeah.
With the technology fix, I mean, you said that.
Yes. No, exactly. So all of this is holding technology fixed in the late 2010s. So and that's why the most important thing to remember, like say RX, it's not coming from Medicare Part D because the way we did it mechanically is that we are holding the mapping fixed in the late 2010s after kind of 10 years of Part D. So this is, if you just look at the raw data, there's like much bigger increase in RX because kind of suddenly kind of Part D came in the middle. So that's not what's going on here. Yeah, like, but hospice, my guess is going to be part of inpatient. Yeah, I'm almost sure. I should look. Yeah, Natalia. So we didn't break it down. So this one is all total spending by category. So I mean, again, it's like what I did before with the 71% is like the overall average. Like you could do some back on the envelope calculation and do this. We haven't done it. Yeah. Right.
Thank you. It seems like the nursing home narrative is more that, you know, over the decades, there are few people who have other, you know, younger kids or whatever will take care of them at home. And that is why the nursing home spending is going up, which you wouldn't capture here.
Correct.
Right, but it's not, I mean, that process is the same, probably going into like category 5 is sort of the number of people in total is going to determine that number, not quite other social changes that are resulting in more people needing nursing home care as opposed to.
Yeah, there would be, yeah, I agree. So this is per 66-year-old, but to the extent that's a per 66-year-old. So to the extent there is.
In some sense, it's kind of baked in that you only go into nursing home if you get a morbidity 5%, like problem.
Yeah.
To some extent, right? And since the technology is the same, that the probability of getting into the nursing home is kind of the same. As long as unless the population increases.
Yeah, but my point is that the narrative, so the narrative that, again, I mean, we can argue about narrative, but it's a bit subjective. But the narrative that I hear when you see people, oh, nursing home is going to be, we need more nursing home because people are getting older. I think the story that you hear is basically we'll have all these 95-year-olds that are very frail out there. They can be healthy or sick, but they're very frail because by 95 you're very frail, and they need support, and we'll have more of them. And again, partly we kind of knew it from the random forest mapping that it didn't show up, but this is just kind of showing you this in a different way. So it's basically it's not that. So because the health index doesn't change too much, you just extended 3 years long. So that's not the story. Yeah, Luca.
This is not really a statement about our changing treatment or anything, just about what the cohort of 66-year-olds look like in 1993 versus
100%. Yeah, 100%, exactly. And that's a decision that we made, but partly if you start changing, then everything is changing and I'm not sure what pins anything down. So it's kind of more of a conceptual, if I'm a policymaker, like, well, yeah, I don't want to hold this fixed, I want to change policies, so what it happened, so we're not doing any of this. It's an academic paper. So taking stock, let me, what's the key thing I want you to take, at least at the high level. So if you look at Social Security, I haven't showed you anything, I just showed you healthcare, but Social Security is like how many years are you're alive, because you're getting basically a check from Social Security for every year you're alive, and you stop getting it once you die. So the fact that people live longer, that means that sort of, we are basically Social Security, again, per 66-year-old are committing 418,000 versus 360. Public health insurance, that's what I showed you, times 71%. So that gets you this. So if you look at the total, that means that basically as a government, as the federal government, you're on a per 66-year-old, you're kind of on the hook for $80,000 more for every 66-year-old, going back from the early 90s to the late 2010s. And it's about 2/3, 1/3 Social Security and Medicare. Okay, so that's kind of the fact. And then the question is, okay, I guess the way I think about it is like, the government was totally passive here because the rules of both Social Security and Medicare are kind of fixed, and now kind of the demographics and the morbidity is changing, and it's an entitlement program, so just now they're on the hook for more, not because they made any active decision to cover more, just because kind of people are kind of living longer. And then that leads to some sort of question, the changing the demographics and morbidity, or maybe even kind of question the original kind of early 90s institution, were they even optimal for kind of morbidity and mortality kind of back in the day. So for this, you need to have a little bit of a framework and a model. So that's kind of what I'm going to kind of go to next. And okay, so let me tell you what we're doing. And actually this is a little bit, some of it is still in progress, but hopefully you'll get the key gist of this. So what's the simplest model we could have kind of written down? So apologies in advance that we are ignoring a lot of important stuff that's going on. So you start your elderly life at 66. You start with some initial wealth, W66, and with some initial health state. Again, health is going to be the same 1 to 5, the same kind of 1 to 5 category that I showed you before. So you'll have like your 66-year-old kind of health state, which is like 1 to 5. You have like just a regular CRRA kind of utility from consumption U of C, no bequest motives or anything like that. And then health follows basically, and that's related to, I think, Nikhil, you were asking, like like an exogenous Markov process that is not affected by how much you spend. So spending here is not going to be discretionary at all. So you'll have a probability of death given your age and given your health. So if you're a 71-year-old with health category 3, you're going to be attached to it like a probability of death. You'll have a transition matrix, same transition matrix as we did before from your, it's a age-specific kind of your health state kind of in last year affecting the probability of kind of your health state in the next year. And then once you have a particular age and a particular health state, there would be like a distribution of spending that is going to tell you how much you need to spend in order to kind of call it like fix your health situation, okay? So that's like the key component that we are kind of reading almost directly off the data, with no real assumption. It's mostly kind of, how granular we model it, but it's really just reading off the data. And the key assumption for most of what I'll show you, I'm going to assume that sort of basically once you have a health spending shock, which is a combination of how sick you are in terms of age and, what's the random kind of spending that it comes with, then you kind of have to spend it. So you don't have a choice whether to spend it or not. You have to spend it. And the government is going, depending on the Medicare cover, the government is going to cover whatever they cover, and the rest of it you're covering out of pocket. And then if you don't have enough money to cover this out of pocket, then the government is kind of on the hook to cover you up to kind of some C lower bar, C floor, which is some sort of think of like a food stamps or something like that. Okay, yeah. That would be, so all of this I'm taking as given. Think of this, you go to the doctor tells you what to do, and you just do it. And I'm not saying that's what should happen or what will happen, but that's the way you need to kind of put some limit on how much you're going to make up assumption given that you have nothing in the data to guide it. So in the model, we are basically assuming that you have no control. They tell you what to do and you just go do it. And if you have not enough money, then they cover it because they give you the food stamps. And then the part in progress, I'll try to get to it in the very last minute. I'll put in some sort of waste in the medical spending, call it ex post moral hazard. For now, just assume that kind of the no moral hazard at all. So given this, what the model looks like, so basically your choice of C of consumption is somewhere between the minimum that the government guarantees and sort of, your initial wealth, your social security payment for the year, minus sort of your out-of-pocket spending, kind of out of your M. M is your kind of health spending shock. And you basically have like a standard sort of Bellman equation where kind of the state variable is the spending shock, your wealth and your health. And then you have utility, you have some discounting, which for now we are going to assume 1, but it doesn't matter too much. And then if you died, nothing. And then if you stay alive, then you have like double integral over sort of your next year kind of health state. And then sort of the static sort of spending shock, which is conditional on your health. Okay, so it's the most, I think, the simplest model I think I could have written down. And then wealth is just, as you can imagine, sort of your wealth next year is basically what you had last year plus your social security minus what you consumed minus the spending times sort of whatever interest rate. Okay, so that's nothing kind of non-standard here. This one, this is what I actually want to talk about. So before I'll show you, I'll dump on you some results from the model. Let me just try to run by you sort of what I think is the right way to think about the trade-offs. And when I mean trade-off, the way I think about it, the government has a bunch of money to commit to the elderly. We're not going to touch this in a way. Let's have it as a budget neutral thing. And the question, do we want to kind of one way to think about the policy question is like, let's not take money away from the elderly or give more money to the elderly. Let's just keep the money to the elderly. But are we spending it the right way between Social Security and Medicare? Because it's really kind of the same amount. These two programs are going to the same people. Of course, but they're like redistribution within it, like the sick are going to benefit more from kind of more Medicare and less Social Security and vice versa. But overall, as a group, they're getting kind of basically, they're the recipient of this money, and to what extent the government want to kind of basically move stuff around between these two. And the way they move stuff around between these two with current policy is like Social Security, they just decide what's the check they are going to write to each person who is alive for every year they're alive. And for Medicare, they're going to decide what share of the spending they're going to cover. Right now, we said 71%. And the question, do they want to kind of, if you want to cover more Medicare, that means you need to kind of reduce the Social Security payment and so forth. So that's the exercise we have in mind, yeah. So for now, we are kind of more or less taking it off which is more or less the current policies, which again, you could make, actually it will come up, but right now we are basically assuming it's fixed for everybody. We are not allowing kind of within age, but totally, one of the questions to what extent it should be varying by age. So if you think about this trade-off, Medicare versus Social Security, or public insurance versus public annuity, so what are the three forces? The first force, this is like, I think that goes back to Arrow 63, or maybe even earlier, is basically, if you think about optimal kind of health insurance coverage, I think Arrowhead back in the 60s, he had this result, which is very natural, is basically condition kind of for some sort of budget neutral thing. You want to basically kind of make it the lowest kind of variance for people. So because of risk aversion, you want to have like a fixed deductible. Once you have Social Security to the mix, deductible can be negative in a way. So basically what it means is just, if we could only think about static risk aversion, then you want to throw everything on Medicare. You want to cover 100, again, we have no moral hazard now. So you want to cover everything on Medicare, cover everything, and then whatever money left, you can kind of put in Social Security. So that's the static risk aversion. Let me jump to the third. The reason you might not want to do it because you might worry about moral hazard that can take different form, either behavioral kind of ex-ante moral hazard or ex-post because the healthcare system is wasteful and stuff like that. So there might be some extra overhead on Medicare spending that maybe doesn't exist as much when you send people kind of checks directly in Social Security. So that's the other one. But then the third one, that's probably the most important one from the dynamic exercise, the dynamic, I mean, if you think about what changed from the early 90s to the late 2010s, it's really like the static risk aversion didn't change too much. And sort of, and the moral hazard stuff, let's assume it didn't change too much. The main thing that changed is basically what I call the dynamic backloading. And at least for us, initially we were getting this result, we didn't understand it. Now we think we understand it better. Here's a result that, again, we won't have time to go too deep into this, but if people have no access to kind of, basically kind of private annuities, either they don't have access or they just don't use it, like a whole literature about the annuity puzzle and the fact that people don't annuitize at all. And so basically, it's kind of a, let's see if I can do the intuition on the fly. So when I'm thinking about consumption today versus consumption tomorrow, the way I kind of basically trade off consumption tomorrow to consumption today is kind of 1-for-1. Because the only reason I want to not spend another dollar tomorrow is because if I am alive next year, I will be having this extra dollar. So I'm going to think about it from an ex-post perspective. Condition on being alive next year, I might want to save this dollar for this year that I'm alive. If the government is optimizing for me, a dollar tomorrow for them is cheaper. Because 20% of us, if we are like 90, 20% of us will die. So for them, the conversion rate between kind of next year and this year is actually 80 cents on the dollar, kind of for kind of next year's spending. So again, I can undo all of this if I have access to private annuities, but if people are not using private annuities, then sort of actually the optimal social security schedule, which is not the current schedule is flat, but the optimal social security schedule is to kind of backload it, to basically govern you kind of more later on. Okay, it can be either in the form of like, age-specific social security payments, and actually if you do like the full model, it's more in the form of like deferred annuity. For 10 years you get nothing, and then starting at 80 you start getting money or something like it. Doesn't matter. The point is, and that's again, it took us a while to find it out, the point is that sort of if we are, at least our baseline assumption is that social security checks are fixed over time or over age, then one thing that Medicare coverage does is basically, because you're getting sicker over time, is backloading sort of your payment through the health, because health is correlated with age and the current schedule is flat in age. So that's the dynamic stuff, and that's the part that is going to be responding to the changes in the demographics between the early 90s and the 2010s. So that's the three kind of forces that are in play that basically now you need to quantify them. And now, so then we calibrate the model. I'm going to go fast, but we calibrate the model basically of the stuff that you saw from the data. And then what the exercise is basically, let's solve the model with the early 90s transitions, and let's solve the model again, with the late 2010s transition, and kind of compare and contrast. And let me skip this. So, okay, so a few things, and again, some of these numbers will change as we are kind of making progress there, but let me just give you the current highlights. So the circle, so this is for Medicare, this is for Social Security. The circle I highlight is the current level of policy. So the 71% of Medicare spending and about $22,000 per year of Social Security check. Basically, this number says that sort of relative to getting a dollar kind of in the mail, spending this extra dollar in Medicare form, in expected dollar, that's like people value it at like, at about 2.3 kind of dollars. So Medicare is more than twice more useful than just kind of a dollar kind of to your pocket. And Social Security, it's about kind of 1.6. So both of them are useful kind of at the current level. Again, we're talking about the market. Suppose I want to throw at the system $1 extra per person. Either one of them is better than just giving this to people, but sort of Medicare in the current way without any moral hazard, Medicare is more useful, partly because without moral hazard, we have the two positive things for Medicare and we have none of the negative stuff because of I just didn't account for any moral hazard or waste kind of in the moral hazard stuff. If you look at what it means, so Social Security is becoming sort of, between 93 to 2007, you value it slightly less, and Medicare, you value it less, and depending on moral hazard now is a parameter that is moving from left to right here. sort of, so moral hazard is not by design, it's not affecting the value of social security, but it makes the value of Medicare kind of lower, and the 2017 to 93 is actually making the difference kind of even more pronounced. And when this cut is basically when the marginal dollars should go to social security, when they cross the blue and the red. And yeah, let me just stay there. I mean, the question is like how to, I mean, I think the key question for us at that point is like how to model exactly moral hazard in a way that's credible, because we can kind of basically the way the top here is basically the elasticity. We can calibrate moral hazard using the 0.2 elasticity from the round experiment. That means it's too high of a moral hazard. That means like most of medical spending is kind of too wasteful. But I think you can basically get a lot of results just by changing this parameter. So the question sort of what's the most credible way to do this. So let me just conclude. I mean, it's I think the main thing to take away is that, you know, people are living longer and mostly kind of the extra years are healthier. Total spending is about 80,000 per 66-year-old kind of extra committed, with maybe 2/3 of them are social security commitment and 1/3 is medical commitment. But all of this is kind of an opportunity to rethink a little bit how you know, we are having two separate programs kind of administered by two separate entities still within the federal government, that giving the money to the same set of people. So it's kind of a little bit idiotic to not think about how the trade-off between them and to keep them separate, given that they're kind of coming from the same place and going to the same place, but kind of administered separately. So I'm not sure I have perfect answers, but at least all these changes makes us kind of want to think about it a bit more. Thanks a lot.